We have Katy McFadden, midwife from Brooklyn, New York. Thank you for joining us. 1 second.
And you swear or affirm that the testimony you're about to give is true?
I do.
Okay.
Chairman Rivera, Chairman Godfrey, members of the Senate and Assembly Health Committees, thank you for taking the time to listen to our testimony today. My name is Katy McFadden. I am a midwife and a registered nurse certified in neonatal intensive care. I recently resigned from my position as a staff nurse in the neonatal intensive care unit at SUNY Downstate Medical Center in East Flatbush, Brooklyn, where over 90% of our patients are Black. On August 9th, 2017, I emailed my supervisor to ask when we could expect more nurses describing unsafe patient care conditions in the unit caused by understaffing. There seems to be a lot of consequences for a nurse who doesn't do everything she should in a shift, and no consequences for the administration that asks us to do more than we ever could, I wrote. 20 hours later, Decheka Floraman, a mother of 6 who had just given birth to her twins, who are being cared for in our neonatal intensive care unit, died of preventable, staffing-related complications. In the months following Mrs. Floraman's death, I sent 4 more emails to increasingly higher levels of the hospital administration, trying to raise the alarm of the imminent peril our patients faced due to understaffing, including the warning it is only a matter of time before another serious event occurs. On November 28, 2017, 4 months later, another Black mother, Tanesia Walker, died of preventable causes shortly after giving birth to her first child at SUNY Downstate. What I was too busy and traumatized to put together at this time were the headlines in the news published the same weeks I was sending frantic emails detailing how Governor Cuomo chose to unlawfully withhold disproportionate share hospital payments, huge sums of federal financing to reimburse hospitals for services they had already provided, which sent public hospitals into hiring freezes. The mechanisms to improve safety and prevent another maternal death were obvious to us in the fall of 2017. But the resources needed to implement those improvements had been intentionally withheld from us by the governor of the state from the hospital the state runs in the neighborhood the state itself segregated. Black birthing people are 12 times more likely than white birthing people to die of pregnancy-related causes in New York City. Research shows us that that disparity would drop by 47.7% if Black women gave birth at the same hospitals as white women in this city. In other words, half of the Black-white disparities in maternal outcomes is due to the lower quality of care provided at a concentrated set of quote-unquote minority-serving hospitals, many of which are public, therefore run by the state, run by the government, and systematically disadvantaged by our separate and unequal system of health financing. Quality is worse at these hospitals because staff and services are missing. Staff and services are missing because we cannot afford them. We cannot afford them because reimbursements from public insurance are considerably less than the true cost of care, and we care for a disproportionate amount of patients on public insurance because of historic and ongoing racial segregation and economic disenfranchisement. Funds intended to compensate for the inevitable budget shortfalls at institutions serving a disproportionate number of patients on public insurance instead go to private, disproportionately white serving facilities because of laws passed by this predominantly white legislative body and upheld by our white governor. Even in neighborhoods with better funded and safer private hospitals, widespread insurance discrimination causes de facto racial segregation. And while insurance discrimination is illegal, then Attorney General Cuomo refused to prosecute the last case that was brought against it to challenge this practice. Racial health disparities have existed since race itself was created as a tool for socio-economic domination during chattel slavery. In 1850, our Constitution counted most Black people as 3/5 a person, and the white-Black infant mortality was 1 to 1.5. In 2019, the public insurance covering the majority of Black birthing people pays half as much as for obstetric care as the private insurance covering the majority of white birthing
Ms.
people.
McFadden, if you
Yes.
could wrap up, please.
And the white-Black infant mortality rate is worse at 1 to 2 to 3. I just have 4 more sentences. Private and public insurance represents a separate and unequal system, and their disparate reimbursement rates reflect the hierarchy of human value our society has pathologically carried with us since slavery ended. We've never stopped having racial disparities in health because we've never started valuing the lives of all people equally. A single-payer system eliminates the funding disparities that drive racial health disparities in New York. For this and for all of the reasons presented before you today, I urge you to pass the New York Health Act. Thank you for your time.
Thank you, Ms. McFadden.
Thank you.
Several times during the day today, I've been thinking, I'm really glad that I sponsored the Midwifery Practice Act in 1992.
We're glad you did too. Thank you.
You folks make me proud. That's it.
I just have one other or 2 other comments.
If you could quickly, madam.
Yeah, you mentioned the Maternal Mortality Review Board. The purpose of that is to determine what were the underlying factors in maternal deaths and offer recommendations. I'm telling you right now what the underlying factor was in at least 2 deaths that occurred in 2017, and it was insufficient staffing related to insufficient funding. And MMRB is going to tell you that maybe in 4 to 5 years after who knows how many more women have died. We don't have time to keep waiting, and I urge you guys to urge people in the next session. There's a moral imperative for us to pass this. Thank you for your time.
Thank you, ma'am.
Thank you.